The medicines for epilepsy that interact with contraception include a group we call enzyme inducers. These are drugs like carbamazepine, phenytoin, phenobarbital of the old drugs, but in addition there is lesser enzyme induction by some of the newer drugs such as oxcarbazepine and topiramate. In addition, the medication lamotrigine is affected by the hormonal contraceptives, even though it's not affected, it doesn't affect the hormonal contraceptives. The hormonal contraceptives that are typical in birth control pills will reduce the lamotrigine levels by about half. So these enzyme inducers reduce the level of the hormone, and as a consequence may lead to higher pregnancy rates. The most reliable reversible contraceptive are IUDs, and in particular IUDs with hormonal components. These hormonal levels do not get into the bloodstream and affect the anticonvulsant medications, and the medications do not affect them. Women with epilepsy in general have normal babies. The vast majority of them have normal babies. A physician should discuss pregnancy issues with a woman of childbearing age whenever a prescription is written. It's important because half the pregnancies in the United States are not planned, and this percentage may be higher even for women with epilepsy. So if you don't talk about these issues very early on, then there may be an unplanned pregnancy, not necessarily unwanted, but then it's too late to go back and reconsider all these issues. And if you don't do that, you're not doing adequate informed consent to the woman. The issues that should be discussed with a woman before pregnancy include choice of the anti-epileptic drug just as you would for any patient. Trying to pick one that fits her seizure type and will be likely to control her seizure type and not cause other side effects. But in addition to that conversation that I have with men, for women I need to discuss with them what the relative risks are across medications for malformations or for neurocognitive or behavioral development. In addition to this initial informational that's given to the woman at the time of the original prescription, or at the time that a physician is taking over care of a woman to make sure that she's received this information. This should probably be repeated about once a year because their considerations, their life situation may change over that time, and in addition they may forget, so it's important to continue to repeat these things. Two other things that I really emphasize are that if they get pregnant, do not reduce the medications. There have been disastrous problems where the women kind of thinks that maybe by reducing the dose they're going to protect the baby, but in doing that it may trigger seizures, which can be more detrimental. It's also important that they contact their physician, their neurologist or epileptologist that's following them if they do become pregnant, because we repeat the counseling at that time, talk specifically about epilepsy issues, but more importantly, we will consider for some drugs monitoring them on a frequent basis about once a month, because there's changes in the levels of the medication because the clearance, the getting rid of the medication by the body changes during pregnancy, and we have to review those types of things. Finally, a very important thing to talk about early in woman's management or treatment for epilepsy is the need for folate. This is actually something that all women of childbearing age should do, as the CDC has found that folate that is present at the time of conception in those first few weeks after conception reduce malformations in the general population. But we've also seen that folate that's taken at the beginning of the pregnancy improves the cognitive outcomes of children that are exposed to anticonvulsant drugs. You can't wait till you get pregnant because then it's too late. By the time you find out you're pregnant, you're already through those critical first few weeks that the folate needs to be there. For some drugs, we give a little bit more folate because the drugs may interfere with the folate, like enzyme-inducing drugs or lamotrigine or valproate. But it's critical that they get in the habit of taking that every day along with their anticonvulsant drug, so that if there is a pregnancy, that they'll get the best outcome they possibly can. That's something the woman herself can do to improve her pregnancy outcome. The first indications that there were possible risks from exposure to anticonvulsant drugs was in the 1960s. And in the 1980s, we knew about spina bifida risks at 1.5% for valproic acid. But it really was not until the 2000s that we began to delineate differential risk on the basis of the several large pregnancy registries and also other studies like our own NEED and MONEED studies. And what we've discovered over the last decade and a half is that there's substantial differential risk across medications. The medication with the highest risk for malformations is valproate, with intermediate risk for phenobarbital and topiramate, and the lowest established risk for lamotrigine and levetiracetam, and a little bit higher for carbamazepine, and about the same level as levetiracetam and lamotrigine for oxcarbazepine, and a variable response to slightly higher for phenytoin. Unfortunately, for most of the other anticonvulsant drugs, we don't know the rates for sure. In regards to autism, there's a clear linkage between risk for autism and exposure to valproate, but for most of the drugs, we don't have clear indications of what the risks are in that regard. The medication effects on cognitive and development, we have clear indications that valproate causes an 8 to 10 IQ point drop overall compared to other commonly used anticonvulsant drugs. So it has the highest risk for cognitive impairment, language delay. We know that lamotrigine, levetiracetam, and carbamazepine have really low risk in this regard. In regards to VICE after the baby is born, in part that depends on the types of seizures the woman is having, but if they are having convulsions or atonic seizures where they drop or even focal aware seizures where they stare and lose awareness, I'm very cautious to advise them to not bathe the baby by themselves, because the baby would flop over during the seizure by the mother and might drown. If they have jerks or convulsions or these types of seizures, even seizures of loss of awareness, I frequently advise them not to carry the baby around just with their hands, to use a sling, maybe use an umbrella stroller to scoot around the house, play on the floor, play on the bed, reduce the amount of time that if she had a seizure, the baby could drop during that time. I strongly encourage them to breastfeed if they want to. We have evidence that from 3 studies now that breastfeeding while you're taking anticonvulsant drug does not produce any harm to the baby. Our latest data suggests the levels are quite low, and our study when we assessed the kids at the oldest age, 6 years of age, the kids were actually smarter that were breastfed during that time. As the child gets older, the mother should watch out to see if they see any delays in development. Again, the vast majority of the kids are going to be normal, but because they're at a little bit increased risk, if you see a delay, the woman should be referred to see her pediatrician and have a low level of threshold for referring to get a full evaluation, because early intervention can really help the children.